Good evening, everyone. Sorry, we're a little bit late starting. So just wanted to welcome everyone to our webinar. It's been 6 weeks since our last webinar, and I'd like to first acknowledge that we're meeting here tonight on Magana land, and I'd like to pay respects to elders past, present and emerging, and acknowledge wherever you're meeting tonight to pay respects to the elders on the land of which you're dialing in or watching online from tonight. So tonight we're going to go through a few different things. We've got Dr. Louise Flood, who's going to first of all present on a CDCB update, and we have Dr. Tom Dodd from SA Pathology, who's going to share with us where we're at with testing, and we have Dr. Jenny Gould from the GP assessment team, and Dr. Chris Moy from the AMA, and myself, Dr. Emily Kirkpatrick from the RACGP and SA Health as well. So we'll start with Louise first of all. I'm just going to check, Louise, that we can hear you.
Hello, everyone.
Thanks, Louise. So we'll hand over to you and go from there. Thanks, Louise.
Hi, everyone. Thanks for joining us again, and hopefully we can provide some more information for you. Emily, I assume you'll move the slides forward for me. Thank you. I was just doing the slides for today, and I found an old presentation, and I thought I'd just go through a bit of a summary, and I actually found that a lot of things hadn't really changed very much from when I did the presentation back in March, but I thought it would be good just to run through what has changed. So the disease is still called the same as it was a few months ago, but the clinical features, one thing that we did know now that we didn't know a few months ago was about the loss of sense of smell or taste that is now in that list of clinical features to look out for in someone who has suspected coronavirus disease. Next page, please. I'm not aware of us knowing any more about the reservoir. The incubation period is pretty much the same. It does seem to be a little bit shorter sometimes than that longer period. Often it's only a few days. The infectious period, again, we still don't really know, but we do have that infectious period is likely 2 days before the symptom onset. Initially, we weren't even sure if people were infectious before symptom onset. Then we had it at 1 day, and now it's at 2 days. We do know now that asymptomatic infection does occur, and that is potentially is infectious. Just regarding that clearance, that's as per the CDNA guidelines. In most cases, people will be able to be cleared around 10 days after their illness onset. They also have to meet other few criteria, but that's approximately how long the infectious period is. The reproduction period, again, it really does depend on what environment the person is in and how crowded it is and things like that. But it's still, it's estimated to be around that in the two sort of area. Regarding the transmission, it's still thought predominantly to be droplet and direct contact, not thought to spread through food. There is still some discussion about whether it's airborne. That's not thought to be a big mode of transmission, but that is still, there's still a little bit of scientific debate around that. But it is predominantly thought to be the droplet spread. The susceptibility, it's a new pathogen, everyone should be susceptible, and there is still a lot of uncertainty about whether people have ongoing immunity. It is a very new disease, as we all know, but it hasn't been that encouraging about whether or not someone will have ongoing immunity to this infection at the moment. Next page, please. Still, the prevention hasn't changed. It's primarily infection control, encouraging that physical distancing, encouraging frequent hand washing, cough etiquette, and no vaccine yet, although there are multiple vaccines currently being trialled. No specific treatment, although there has been some progress in that. Particularly as some of the dexamethasone can be used in severe cases, and that is encouraging. We just skipped over something, I can't remember what it was. Oh, back one. Yeah, just about the severity. That really hasn't changed either since when I wrote these slides in March. And then just next page now. Yes, so now just the update on the epidemiology. As you would know from looking at the news, there's large numbers of cases each day. We're up to 14 million cases, and large numbers in USA, Brazil, India, Russia, and South Africa is now on that list of high numbers. Deaths, over 600,000 deaths, majority in USA, Brazil, UK, Mexico, and Italy. And the number of deaths and cases, as I say every time we do this, really depends on whether you're testing. And if it depends on who you're testing, whether you'll detect those cases, and it is always going to be a large undercount. The case fatality rate is around 4.2, so it hasn't changed very much. This is the logarithmic curve of the cases from the first days after that country first got 100 cases for various countries. And you can see USA is still right up the top with that quite steep curve. China has managed to keep theirs extremely flat for quite some time. And you can see South Australia there we were doing very well with that quite flat curve. But now you can see that upkick at the end there, primarily related to the cases in Victoria. And here's our updated epidemic curve. You can see in April we had that quite big peak, but managed to control that until the last month or so, where there's been a large increase in cases, primarily in Victoria. So this is just looking at the Australian cases as of yesterday. Australia, we're sitting at 12,000 cases, with 5,000 of those acquired overseas. And you can see that a large proportion of those cases are in Victoria, with over 6,000 cases, and New South Wales has about 3,500 cases. And you can just see the really big difference between the numbers of locally acquired cases in, say, Victoria, where they've got a large portion of their cases are locally acquired, either contact not identified or contact of a confirmed case, compared with, say, New South Wales, where they have the majority of their cases are overseas acquired. And South Australia, we're sitting quite, well, we'll come to South Australia in a moment anyway. So just looking at our confirmed cases in Australia by jurisdiction and notification date, and you can see that of the last sort of month, the majority of cases are occurring in Victoria. This is the South Australian data by looking at our overseas acquired cases. We have just added one to that tally, so we're now up to 306, 124 who are locally acquired and a close contact of confirmed case, and that same 9 who have locally acquired with a contact not identified. That hasn't changed for several months, and we just have one case that's under investigation. We know that case is not locally acquired, but we're not sure at this stage whether it's overseas acquired or acquired in Victoria. So that brings our numbers to 446 at the moment. And you can see our epidemic curve here for South Australia. So the large number of our cases occurred in March and April there, with last locally acquired case where we didn't have an identified source occurring in March. And you can just see the occasional case happening every so often, with our last 2 cases there right on the end, with one that overseas acquired and one under investigation, which, as I said, we know is either interstate or overseas acquired. And there haven't been any locally acquired cases since March. Age and sex distribution still predominantly in the young adults, and well, young adults is the most common age for Australia as a whole, but we've got them in all ages in adults predominantly, not very common at all in children. Part of that will also reflect to some extent testing, but we do know that children are less likely to get disease. So just a little bit on who to test. So it's still anyone with a clinically compatible illness is totally encouraged to be tested. So an acute respiratory infection, fever without any other explanation for the fever, and that acute loss of sense of smell or sense of taste. We now recommend, so recent overseas travel, they will get a swab at day 1 and day 12 after arrival, even if they're asymptomatic. So all our overseas arrivals do go into hotel quarantine, and that's something that our central command centre organises. And then if someone has recent interstate travel, they are required to have a test. If they arrived more than a week, the requirement to have a test came in force on Saturday evening, and so those people must have a test. And if you do not have a test, you are breaking one of the directions and can potentially be fined. So those tests need to occur on day 1 and day 12 after arrival, even if that person is asymptomatic. We're also testing close contacts of known cases, even if they're asymptomatic. Next slide, please. So isolation and quarantine really hasn't changed that much since we did this. I did this slide earlier. So it's basically anyone who's a known close contact and hasn't been wearing a PPE. So if you're exposed to someone in a hospital but you're wearing full PPE, that doesn't mean you're a close contact. If you people who have travelled from overseas or Victoria, ACT or New South Wales need to be in that quarantine for the 14 days since they arrived here. But there are some exclusions for that interstate travel, such as essential workers can go about their work and need to be in quarantine apart from that. Symptomatic people, whilst being tested for COVID, should always be in isolation whilst they're awaiting their results, and until those symptoms resolve. If someone is completely asymptomatic and are being tested for screening purposes, then and they do, so say if they're a healthcare worker or something, that person does not need to be in isolation whilst they're waiting the results.
Louise, we've just had a question come through around if they're under 16 years of age, do they need to have a test as part of, and someone noted that they had read that in the direction that that was the case. Are you able to comment on that at all?
So it's still recommended they get tested, but it's not mandated. Sorry, I should have had that in my little notes there. Still definitely recommended, but it's not, they won't be fined if they don't get a test. So just a bit about isolation and quarantine and what that is. So basically stay at home. Only people who live in that home should attend the home. So no visitors, and there should be so it should be physical distancing in the home. And if the person needs to leave, they should be wearing a mask. And they should only be leaving for essential purposes, such as to receive medical care. If you have someone in isolation whilst they're waiting their results, make sure they know their results and provide them some information. We do have fact sheets on our website. It's a notifiable condition, and actually that is now a notifiable condition ongoing. Initially we had it made a notifiable condition just through a notice in the Gazette, but it is now being listed as a notifiable condition through regulation. So it's notifiable both as COVID-19 and as SARS-CoV infection. So even if it's asymptomatic, it's still notifiable. And it can be notified online, and there's just our website. I think that's all for me.
Thank you so much, Louise. We've had a few questions come in. One was around, and this is for you because you're our public health expert. Should the Victorians, or anyone for that matter, have considered a New Zealand-style hard lockdown early on towards an elimination strategy rather than managing the outbreaks as they occur? And you've been over in Victoria as well, Louise, so you've seen firsthand as well what's happening in Victoria.
Yes, so I'm still in my home quarantine because I arrived less than 2 weeks ago. So I am doing what I must do as a person returning from Victoria. Look, it's always easy to look back and say, oh, we should have done this or we should have done that. And there's always a lot of things to consider when you're considering any lockdown or that type of thing. It's not easy for those people in that situation. It's also, you know, a lot of financial implications for any lockdown. It can have mental health issues for the people involved, and so it's really and if there's issues in the economy, that does have implications for health as well. So it's not an easy decision for any politician to come to as to when to do that lockdown, and it's a big decision, and it's easy to look back and say, oh, whatever should have happened, but it's very hard when you're in the situation you don't know exactly what is going to evolve.
Thanks, Louise. And we've also had a question around essential workers and whether they need to be in quarantine when not working. So, for example, if they're coming from Victoria or South Australia and they come back home, do they need to be in quarantine when they're not working?
That's my understanding, but Emily, you're on the committee with me as well. I believe that, yes, they need to be in quarantine whilst they're not working until that 14-day period is up.
Yes, that's my understanding as well. And now there's that new section in there about the masks as well, particularly if they're coming from Victoria, that they need to wear a mask if they're going out to receive care. They need to be having a mask with any interaction with the community as well. So, for instance, we've just approved some people coming over for exemptions who are coming to fix machines at different hospitals, and they will have to wear masks and have to undergo a very strict risk mitigation strategy so they can repair this essential equipment, and they must be wearing those masks when they're travelling and then when they're fixing the machines as well. Actually, just on the topic of masks, Louise, are you able just to give us a little bit of an update about the evidence for masks? That's been a common question coming into general practice, and is there any sort of stance on whether we should be wearing masks currently at all, particularly if we're seeing asymptomatic patients?
So, I mean, there's a lot of discussions about masks, as you said, and there is going to be some updated guidance regarding masks coming out from the Commonwealth soon, if it hasn't come out yet. Because, as you would know, in Victoria, they now are recommending masks if you leave if people leave their home and they're in one of the higher risk areas, including Melbourne. So that's not what we need to recommend here at the moment. We don't have community transmission. This is the sort of thing, though, that will be monitored to see how things progress, and it may be something that we need to recommend here at some point, but we're not at that at the moment. As far as wearing masks to see asymptomatic people, I would not recommend that at the moment, unless you're doing, obviously taking a swab and the procedures that you might need the mask for, unless that person is a contact of a known case or has recently travelled in one of the groups that are needing to be isolated. But if they don't fall in any of those groups, there would be no need to wear a mask unless you're doing a procedure that would require a mask anyway. At the moment, that may change as the situation evolves.
Thanks, Louise, for that. That's very helpful. Now, I'm going to hand over now to Dr. Tom Dodd, who's the Clinical Services Director at SA Pathology. Tom's been very busy checking on border patrols, Tom, and making sure that people are being tested across the border. And no doubt that's been a common question for GPs around that, in terms of what happens with this border testing process. And are they receiving forms? Are they going to GP clinics? Are they being tested at the border? So it'd be great to sort of have a bit of a chat around that. I'm just going to get up your slides here on the screen and go from there. Hold on 2 ticks. I think that will show all my emails there. Let me find, sorry everyone, there we go. That should open up now. If I can do that. Perfect. Great. All right, thanks Tom.
Thanks Emily, good evening everyone. Yes, so obviously since we last spoke few weeks back, the emphasis has been around testing, particularly also symptomatic people, but also a number of asymptomatic target surveillance populations. But clearly things have moved dramatically in the last 3 weeks because of Victoria, and you can see this table, this bar graph here shows our testing rates over the last few days, which has steadily risen. Today or yesterday, SA Pathology processed 2,500 tests for the whole state. Now we're just under 200,000 tests, so that's beginning to escalate dramatically. A big contributing factor to that in the last few days, of course, has been this mandatory swabbing of people returning to South Australia from Victoria. So as you'd all know, it was highly recommended and is now compulsory for travellers to have a swab on day in the first 24 hours of entering South Australia and then on day 12. So to support that, we've now got 3 points working with SAPOL at Bordertown, Yamba outside Renmark, and Princess Highway outside Mount Gambier to take swabs actually as people cross the border, and we are swabbing a lot of people. We'll continue to do more in that space depending on the other crossing points where there's heavy traffic movement as well. Beyond that, obviously everyone has then got to get day 12 swabs, and probably the easiest option is to make the most use of the drive-through services, of which there are many now. SA Pathology obviously has the 2 large ones at the Repat and Hampstead, but of course ACL have several, ClinPath have several. So if you've got people ringing into your room saying, how can I get a swab? They can just show up. They're given request forms. So when people cross the border or arrive at the airport, the police obviously speak to them about what the expectations are and hand them 2 request forms, which are requested by Professor Spurrier as the requester, and they can present essentially anywhere. Many people are going to the COVID clinics and the hospitals as well, but by far the easiest thing is to use the drive-throughs. We are going to stand up more drive-throughs to support this in the coming days as well, in locations where there's less coverage. These people obviously are all, well, the vast majority will be asymptomatic, but essentially they should come in, have their swabs done and go back to quarantine. So the best way of doing that is clearly through the drive-throughs. The other point I think for tonight is to mention the much awaited serology test will be available as of next Monday. We're going to use a Roche platform. It's very well validated. It is the sensitivity of the test improves from around 60% in the first few days of the illness through to 100% around day 14 of the illness. It tests for IgA, IgM and IgG. I think the most important thing to note though is the specificity is 99.8%. But of course what that means is in South Australia's population with an incidence of I think it's 0.03%, if you randomly test people, you will still have the vast majority of positive results in fact being false positives. So there will be some guidance around which patient group should be tested. Obviously it'll be useful for people that have had COVID compatible illnesses previously who didn't have a PCR test, or where you've got an unexpected positive or an equivocal result. What we will be asking people to do though is to make contact with Louise's team with the CDCB and get prior approval before ordering the test, so that we are concentrating the testing population, so avoiding the risk of having confusing false false positive cases come up. But we'll be writing to everyone around that in the next couple of days ahead of making the test available.
Yes, I've just filmed a video which is going live tomorrow about serology, and there will be a really good fact sheet. There's been a paper that's been written about serology because it is an important tool to have, but it's making sure it goes through those processes. And I'm sure, Louise, you'll probably have something to say as well about serology as well.
Yeah, I think it's the main thing is that risk of a false positive. So because we have we don't have community transmission, that with even if you have a really good test, which is what we do have, if you have a very low prevalence in the population, then even a super good test will end up with a lot more false positives than true positives. And then that makes it very difficult to interpret. And you know, what do you do with that? Is it really a case? And the other thing is serology is obviously no good with that acute diagnosis. So that is always, if you've got someone who has an illness now, then PCR is the way to go. But we are very glad that SA Pathology have brought on the serology test, and we've been using this recently with some of our new cases to help determine whether or not they're an active case or not, and also determine if they actually are a true case, as well as the other way it's really useful is if you have a couple of cases, but you're not sure if they're linked, but you're quite suspicious they're linked. And you can then test that the missing link between those two and help link up a cluster of cases.
Thanks, Louise, for that. So you'll hear more about that over the coming days, and we'll send that out via email as well, and it will also be online. Now, we've had a question come through. Is there an essential worker testing program? Are you able to answer that, Tom, in terms of who we test still? Coming across the border, the truck drivers, people turning up for voluntary testing?
So in terms of truck drivers, we still are actively encouraging truck drivers to have voluntary testing. But the target currently is around the non-essential travellers. However, that's going to be expanded out over the coming days to some other groups as well.
Thanks, Tom, for that. So I'm going to hand over now to Dr. Chris Moy, AMA SA President, who's going to give us a bit of an update on looks like health pathways, Chris.
I might remind you again, because everything I'm going to talk about today will hand up on me. Look, can I just say, I'm taking the AMA stance. We're really unhappy with Victoria. Okay, so I'll give you the whole gig. But I think they're behind the curve and they're chasing it, and there's a lot of people who feel that way at the moment. So. Look, thank God we're in South Australia, that's all I can say. Now, Health Pathways in South Australia, I brought that up. And how do I change? Sure. What am I doing?
Just next. Yeah.
Yes.
Arrow.
Yeah, I'm doing it.
Is that open?
It is open. Oh, here it is. I'll just press it. I think most of you are going to be keen to know about the telehealth changes. So the telehealth changes happened because of the concerns about just pop-up clinics appearing. Now, I know we've gone from one thing where we were early in the lockdown when there were some patients with no doctor, or there were new doctors coming online that hadn't seen a patient, and then the telehealth items expanded. But then obviously there was a shift the other way, and there was a bit of opportunism. So given the fact that at the moment, particularly in South Australia, there's 90% of all consultations are now back to face-to-face, as I understand it. So that's actually, there's been this move back to this. So as of 20th of July, you have to have an existing relationship with the medical practitioner before you can use telehealth, access telehealth, and that's either have provided face-to-face service within the previous 12 months, or you've had a contact with somebody located in legal practice within the last 12 months. It does not apply to children under the age of 12 months, people homeless, people living in a COVID-impacted area. So if we do go to a lockdown here again, it'll switch back. That's really important to understand. So in Victoria, this is not in effect. And patients receiving urgent after hours or social hours, or those patients are medical practitioners of Aboriginal medical services or an Aboriginal community controlled health service. So just be aware about those changes and understand that, look, it's a type 2 error problem, but it is trying to basically support good quality care rather than just opportunism with regards to the use of the items.
And just about that as well, because one of the issues we had was that some people who are in isolation or in quarantine were unable to get a test and couldn't have a consult. So just so you're aware that was put into the clause that was raised, certainly at our state minister also raised that. That's how we run our hotel quarantine program, is through using telehealth MBS item numbers. So it was really important that was put in there as a clause. So we're really pleased that that's covered for those vulnerable people.
Yeah. Just electronic prescribing is coming. You saw Danny in the paper today. First gave it to himself. Don't know what he prescribed himself.
I think it was his cholesterol. I think I saw the script. You sent me a copy.
He needs to get a good GP.
Yeah. Anyway, Danny, so it is coming. So at the moment, it's in what we call communities of care. It is being rolled out. So it requires, obviously, ideally a relationship between a general practice and a pharmacy or several pharmacies, because obviously there are going to be pharmacies who will be ahead of others, but that's probably something to start to think about. As I said, initially there'll be this token model, so the pharmacies will need to accept this token and later active script, which would be a lot easier. And there's electronic prescribing things to tick off on, and I would suggest going to ADHA, and there's a Australian Digital Health Agency, and there will be a link on the Health Pathway website to this, just about things to prepare your practice. I thought I'd also bring up, because I have this other hat being on the Digital Health Agency Privacy and Security Committee. Given the recent increased use of technology, there's been a lot of questions about IT security and worries about hacks and ransomware and things like that. And also about the use of cloud services, so you can be a bit more mobile, and also the use of online conferencing technologies, not so much for telehealth, but more for things like meetings and the like. So these resources have been created about questions to ask your IT vendors about whether you're doing enough for IT security. It's actually got this on the website. There's actually a really great checklist which you can hand your IT provider, and they'll hand it back to you and you actually score them. So it's actually quite a good thing to look at to make sure that they've done all the right things. Cloud services and technology, yeah, so the questions about Zoom and things like that and using other, being frank, if you look at the actual information about it, there's actually quite a lot of warts on all of them, okay? Not just Zoom. The final thing was, oh, sorry, there was one thing I was going to mention. Emily asked me to talk about the ECG thing, which was the ECG item number change. So that was bloody ridiculous, basically. So what has happened is the ECG item has dropped from $31 down to $16 or something like that, the MBS rebate, which is just ridiculous. It actually slightly goes against the actual MBS review report, interestingly. So they've pulled this out of the hat a bit. So the AMA has actually made submissions to indicate that this is silly, straight to the minister. So hopefully we'll kill this off pretty soon, but it is ridiculous. Right, now just quickly, a couple of little things. So the good thing that happened yesterday was the passage of the COVID-19 Emergency Response Amendment Bill. So last year I was involved in getting some legislation with the Attorney General, Vicky Chapman, to have it so that emergency responders, primarily at that stage, individuals in emergency departments, including country hospitals, and also those, you know, going to the scene of a car accident, if they were spat on or threatened with biological fluids in that situation, they would be covered. And so that was a big change last year. Now, for COVID, there's been the addition, there's been some changes to strengthen that. Now, initially that was because of the potential pharmacy trial that was supposed to go on. But then there's been this addition where yesterday we had a chat with the minister who asked us about, initially asked us whether just GPs should be put in, and we suggested, well, the only thing would be also good to include all other staff in there as well, such as nursing staff and the like. So it's been medical treatment is provided or medical testing undertaken, but including, without limiting the paragraph, a general practice medical centre or place at which people are screened for COVID-19. So there's a much wider protection. So I think that's a really positive change. And what it means is that individuals who attack you or assault you, and obviously, unfortunately, it would have happened already, but there's a maximum penalty of 5 years, and we've been inserted into there as a group. So I think that just gives wider protection under COVID. Now, hopefully this will be able to continue on after this time, but it's a beginning of hopefully a long-term change to increase the safety of all healthcare providers outside of hospital. So that's all I have to say at the moment.
Thanks, Chris, for that, and thank you for talking about the ECG. That's been very topical online, and certainly had a few emails about that. So look, hopefully we'll see some change and some rethinking of that item number deduction would be very helpful.
Or just some thinking, Emily, might be what would be required.
Some thinking,
They could follow the report, that's the main thing.
Yeah. All right, I'm going to now hand over to Dr. Jenny Gould, who's going to give us a bit of an update. I'm just going to open this, switching between computers a bit tonight. So let's have a look here. How have you been going, Jenny? How's the GP assessment team? Is that still ready to go in case we have cases?
Yeah, so we've got the GP assessment team. We're still ready and available, although we've had not a lot of work, which is a good thing. There's just been a few overseas arrivals, but obviously no community cases. So we're trained, skilled and ready, and hopefully our services will not be required.
That would be good, wouldn't it?
Yes, but unfortunately with Victoria just across the border, one gets anxious, don't we? So
well, I love your SA.gov email address, Jenny.
Oh yes. So I just a reminder, like, to keep on testing, because even though we have had no community cases currently, I mean, we only need one rogue Victorian to sneak across our border and we will be in different circumstances. So Emily suggested that, given there's not been a lot of action on the GP assessment team, that perhaps I give you an update on shared care, obstetric shared care, which is my other hat, and how that's been impacted with COVID-19. So I think for many of you, you'll know that GP obstetric shared care is a model of care that's available to predominantly low-risk women who want to birth at a public hospital, and they have the majority of their antenatal care provided by an accredited GP. I'm not biased or anything, but I think it's a fantastic model. The advantages are around continuity and establishment of the relationship with the GP, which has all sorts of positive benefits for increased breastfeeding rates, management of comorbidity, better mental health, vaccination uptake, etc. And it's usually a really positive experience for the GPs, as patients are generally happy and healthy, and this is a very exciting part of their life as they have a baby. So it also avoids hospital car parking and hospital waiting rooms and wait times. So it's even a more ideal model in this current climate of COVID, where we're looking to keep people's exposure to tertiary hospital settings down. So what does COVID mean? There's many resources available out there which help with the updated guidelines. The MBS telehealth item numbers are also really useful if women are apprehensive about coming into the surgery for visits. Business is pretty much as usual for pregnancy care across South Australia. The RACGP produced guidelines for management of pregnancy care, and predominantly that was focused on reducing visits to tertiary centres and reducing face-to-face contact as much as possible, and certainly aiming to keep it less than 15 minutes. So you can see that GP shared care is a perfect model to meet those criteria. Women can request telehealth consults also, so they don't even need to come to the GP surgery. The hospitals across South Australia have done things slightly differently in each centre, but largely they haven't altered their practice very much. The hospital booking visit is usually booked as a face-to-face, but women are contacted prior to their appointment and screened to make sure there's no risk factors for COVID. And if so, they would then be offered that consult on the phone. There are community centres where midwives are out in the community to avoid the busy hospitals, and obviously there's the GP surgeries. Hospitals are using the usual COVID precautions with screening people as they enter the hospital and the clinic area, the physical distancing and the appropriate cleaning and masking when required. They did limit the support people to accompany into the hospital for appointments and for birth down to one person, and certainly no children, but this has been increased. And I noticed on my door in the antenatal clinic this morning at the Women's and Children's, it said this room is suitable for up to 8 people. So I didn't have 8 in there, but yes, so I think our restrictions are being lifted. And of course, there was some concern early on about the availability of nitrous oxide for analgesia, but that's all pain relief options are now available. With the shared care model, women usually have a booking visit at the hospital and then the rest of their visits with their GP, and they return to the hospital at about 36 weeks. Lyell McEwen and Modbury also used to do a 32-week visit if women were interested in birthing in the birth centre for shared care women, and that's not required now. And Flinders also had a 34-week visit, but they've dropped that unless the patient needs anti-D. Diabetic screening was probably the biggest area where things changed a little bit. So the usual screening is with the 2-hour 75-gram glucose tolerance test. This was continued at the Women's and Children's unless women really didn't want to do that, and Flinders, but the Lyell McEwen just opted to do a fasting glucose to avoid women sitting around in pathology centres of waiting rooms, although a number of them have set up rooms for pregnant women to isolate in. There is also still the issue around interstate women coming to birth in South Australia, Broken Hill, Mildura, and they still need to come and they still need to meet the crossing the border quarantine criteria. So they would need the swab at day 1 and 12, as Louise spoke about earlier, and they would need to stay in quarantine for the 14 days. So this means people need to make their travel plans when they're coming for a caesarean or a planned induction, if they're wanting to birth here. With pregnant women, they count as vulnerable patients, even though we haven't particularly seen any issues amongst our pregnant women in the COVID times. But telehealth is a great option if women are apprehensive about coming in. Certainly the first visit could be done quite easily as a teleconsult. If you're seeing women in your practice, keeping the visits to under 15 minutes and maybe seeing them over a number of appointments or doing some telehealth with a face-to-face for physical examination. If women aren't keen to come in to be examined and want to do telehealth, it's difficult to maintain sort of the high standard pregnancy care. You can't really measure blood pressure over the phone or check for a fetal heart. So, I mean, it's really important to still employ those screens. So if women have a home blood pressure monitoring system, fabulous. If not, they might be able to get to a pharmacy or somewhere just to keep an eye on their blood pressure, their weight, their fetal movements, and their sense of growth. Obviously, it's still important to screen for the other problems in pregnancy, so asking about preeclampsia symptoms and domestic violence and mental health is extremely important, especially if you're not seeing these women face to face. There are things you can do, run flu clinics for your pregnant patients, get them to come in at different times of the day when the surgery is less busy, and ensure their minimal waiting time. These pregnant women would be screened just as anybody if they present with symptoms. And I guess the important thing is not only to think about them from a COVID point of view, but to manage them from a holistic care perspective, which is managing all of any other health issues they've got and ensure that they're vaccinated. And we certainly recommend flu vaccine in pregnancy, and that can be done at any time. and also the pertussis, and that's now offered to pregnant women from 20 weeks and ideally before 32 weeks to ensure baby has some opportunity to develop immunity. Whilst I had a captured audience, I thought I would just refresh you about routine supplements, because for those of you who don't provide a lot of pregnancy care or any pregnancy care, you're still going to see women who are thinking about a pregnancy or come in for their pregnancy to be diagnosed. Folic acid we've known about forever, and I think we're all across that one. Iodine is one that was added to the mix, 150 micrograms of iodine a day, which you can get in most of the pregnancy multivitamins. But the new one this year is vitamin D. And so they're recommending 400 international units a day for all pregnant women with vitamin D. Obviously, if people are at risk or have a low vitamin D, then they need to take a higher amount. And then preeclampsia or women who've had a past history with intrauterine growth restriction would need low dose aspirin and calcium. But when you're thinking about vitamin D and 400 international units a day, in their wisdom, whoever chose that number, there isn't actually a product on the market that provides that. So these are the options that you can look at for women, and I suspect some clever person will soon market one that fits the criteria. So I think with pregnancy care, it's like all care in COVID times. We need to remain up to date with the COVID guidelines. We need to think about the holistic health, not just with the focus on COVID, but we need to look at that holistic approach, getting people to have appropriate medical review and recognising the importance of face-to-face when this is appropriate and possible, because clearly it is gold standard care. But obviously, if that's not available, then telehealth will provide certainly some important details. Mental health, I think, is something that GPs were all very well familiar with, and the limited resources in the community. And certainly these are put to even more stretch, if you like, with COVID times. And so if anyone's interested in the shared care program, that's our contact details, or you need any information, Leanne March is fantastic and has the answer to everything. And if she doesn't, she'll find it. So she's a great person to contact initially, and then she can direct you in the right spot. So thank you.
Wonderful. Thank you, Jenny, for that. Now, I'm just going to sneak over here and just see. So really, I guess the other things that just to touch base on was to make sure people felt comfortable and happy with how everything's going with COVID. I mean, obviously, we're very frightened and worried about what's happening in Victoria and where that state is currently sitting. So a few things just to touch base on to give you a few different updates in different areas. So Dr. Tom Dodd's already mentioned around what's happening at the border, so testing with SA pathology at the border, and that they're given 2 request forms with Professor Spurrier's name and provider number on those forms. So if you did have a patient who then rang up your clinic and said, oh, I want my patient to be tested, I want to have a test, and you want to organise that for them, they should have already been given the forms for that. And the forms are given at both the airport and on the hard border as well at the different locations. And now that we're testing New South Wales as well, we're expecting a lot of people to go and seek testing. So you can certainly test them yourselves if you wanted to in your GP rooms. We would still advise that you are wearing full PPE, because these are people who should be in quarantine. So you do need to think about wearing full PPE for that. And it is really important that because they do have the test form, you can just send them to a drive-through clinic as well if you don't want to have them come into your clinic.
No booking required.
No booking required. So yes, really important to be aware of that they can get that test done. And we've updated the website as well to put on the SA Health website to put on there the 2 private providers who are doing drive-through testing as well, ClinPath and Australian Clinical Labs. Really quick turnarounds with all 3 providers. So it's so important to go and refer your patient on. So some of the other questions that I've had come in during the week have been around schools and children testing. So we are still advising that if anyone has any symptoms that they do have a test particularly before they return to the workplace or to the school environment or to childcare, and that they shouldn't be returning to that setting until they're feeling better. And that's because of the fact that we know all those respiratory viruses, they spread so quickly amongst everyone that really that can be quite problematic then when you've got multiple people in the class who have coughs and colds, and that it creates more of an issue for everyone. So please stay home, or advise your patients to stay home if they're unwell. And we are testing children. That was mentioned as well in the questions in the chat box about testing under 16 years. But yes, you can't, because of consent, make it mandatory for children under 16 years of age to have a test. In terms of domiciliary testing, you're still doing the domiciliary testing, Tom? And you can do domiciliary testing with the other private providers as well. So it is really important to think about that. So I know we've had a question posted around that in terms of if you know someone cannot go and get a test, or they call you up, they can certainly do that. It is on the website as well. So hopefully people would look at the testing clinics and could see that that was an option. But perhaps that's something we need to think about in terms of people who don't have that internet access as well. So thanks, Catherine, for that question. Chris has talked through around ECGs and GPs as well, which is so disappointing to see that change come through when that wasn't supported by the MBS as well as part of that review. The other thing as well, we've heard some horrifying stories of interstate travellers just rocking up to GP clinics, walking up to the front desk saying, I'm here to get a swab, or I'm here for this. Look, it's not acceptable. And it's really frightening for the front desk staff to have that happen. So we'd suggest putting some signs up at the front. You're probably already doing this anyway, because we had a big red stop sign at our clinic as well. But really important to try and remind people that they can't just walk into your facility and get tested. So I'm sorry for clinics that have been going through that this week. And we certainly don't tell people to go and see their GP when they cross the border. We provide them with the request form and the list of clinics to go and see. In terms of quarantining, and so so we are you're only allowed, when you're in quarantine, you're only allowed to seek care if it's for urgent medical care. So just to emphasise that, or for seeking a test. So I just wanted to add that, and that was in the Q&A box. Now Jackie just posted around no booking now for the drive-through clinic, Tom.
For the people returning from quarantine, we still like bookings for the GP referred patients. It's partly about managing the traffic flow. We're seeing 300 people coming through some of the drive-throughs on any given day, and we don't want them obviously all arriving at 3 o'clock.
So my experience has been that when you don't need to book that as the GP, you just fax a form through with their phone number, and then the drive-through clinic contacts the patient directly with a time. So that's sort of, you don't have to do it, but there is an appointment scheduled, but you don't have to.
Not for the GPs to book.
No.
We'll manage that with your patients.
But you're saying that the people who are returning, who've got their day 12 swab form, wouldn't even need to do that. They can
just turn up, because we've got to make it very straightforward for these people. They, after all, are in quarantine, and we don't want them out and about.
Can I ask, while we're on the quarantine, something I get asked, or people have mentioned, is some confusion over the quarantine when they return from interstate. For example, we know that they need to quarantine for 14 days, and if they need to leave for an essential medical service, they would mask. But there's some people who've been telling me, well, yes, no, it's okay to have family and friends over if you sit inside with the door open and they sit on the other side. And I've said that this is not okay, but I think it's really important to put that out there, because there seems to be a lot of misinterpretation of that. So quarantine means quarantine. You can talk to people on the phone or Zoom, video, FaceTime, but you don't have people over, even if they're in your garden and you're inside. Correct?
That's exactly right. And I'm sure Louise would be shaking her head as well on the other side, the other side of Zoom as well. And look, it really is so important that people follow all the rules. They have been updated. They're in the direction now that you just cannot have people over. You've got to be on your own. quarantining with no contact with other people, and it is becoming more and more strict, because we've heard of stories where people they've got staying with other family members. That it's just not acceptable. You need to be completely quarantined off, using your own bathroom, not having any interaction with others, and no common areas. And the other thing as well around travel as well, we have that hard border in place with Victoria, so that is that requirement that you do need to apply for an exemption to cross the border in terms of if you are not a South Australian traveller. So you would need to seek, they would need to seek an exemption through the health exemptions generally, rather than through SAPOL as the only source. So they do the SAPOL one, but they also need to do a health exemptions. So just in case you have any patients or know of anyone who's trying to come over from the Victorian border, they do need to apply through that separate avenue, and then it goes to the panel exemptions group. And at this stage, we do still have that border in place with New South Wales and the ACT. However, that still allows for travel across the border if you are not a South Australian resident, but you do need to quarantine for 14 days coming here. And there's not really a lot of exceptions around that, really, to be honest. The more and more strict around how that's applied, those rules. So please be reassured, we are trying to do everything we can to stop people coming across the border, but it's so important that everyone does get tested. And at this stage, no essential travellers are required to be tested. However, that's something that's been very closely looked at. That sort of answered most. We've had a few things come in. How do they apply for a health exemption? So there's a health exemption email that I've sent around previously. I can send it around in the next update, and or they're actually told that at the time with their SAPOL application as well. And in terms of if someone does come from interstate and is self-quarantining in a house with other residents, what are the instructions for those other residents? So it's quite clear now that that's not how you self-quarantine. You need to be quarantining away from other people, so be completely separate and independent. And Louise has been quarantining. You might want to comment, Louise, on what's required of you in terms of the requirements to self-quarantine in your own house, and making sure that you're completely separate from others and not sharing any common areas.
Yes, so what you're meant to be doing is you need to have your own, sleep in your own bedroom, have your own bathroom, and you shouldn't be sharing meal or common areas with others. And if you do, you should, keep that to a minimum, and you ideally should be wearing a mask whilst you're doing that. But I have to say, it's a lot harder in practice than it is when you just say it. It's very hard when you haven't seen your family for a few weeks to see them at the airport and just sort of stand there quite a few meters away from them and say hello rather than give them a big hug. So it is very hard to do in practice.
And just a question we've had come through as well was around how do you get home from the airport? Can you catch a taxi with a mask? Can your family members come and pick you up? Are you able to comment on that as well, Louise?
So, I mean, there is the requirement to wear a mask when you're going to the airport, going back, but yes, you can take a taxi or go get a family member. You should be sitting in the back seat. The person who's travelled should be sitting in the back seat away from that person, wearing their mask. So as far away from that person as they can, wearing a mask. And ideally, it should only be a short trip. If you do have the capacity to leave a car or something at the airport, that's great, but most people can't do that sort of thing. So it's just about minimising that trip. And the other thing is you do have to go directly to the place you'll be isolating from the airport.
Yes, and I unmuted the wrong computer then. And so there's definitely no stopping in at the shops on the way home. I think that's the key thing. We hear of people say, I've got to go to the supermarket and get my supplies, but no, can't do that. Groceries need to be delivered or dropped off by someone else at your door. So we'll leave it there. Thank you so much for joining us for tonight's webinar. And I just wanted to thank all of our presenters, Dr. Louise Flood, Dr. Tom Dodd, Dr. Jenny Gould, Dr. Chris Moy for joining us here. And most importantly, I wanted to thank Adelaide PHN for their continued support with these webinars. We've been extremely lucky that we've been able to host these on such a regular occasion and be able to send it out to all the GPs, practice managers, nurses here in the state to be part of these webinars. Always happy to take feedback as well. If people feel that we need to have another webinar sooner or they want to get in contact, you absolutely can send me an email and we will respond as soon as possible, and I can redirect those through to Tom or Louise or whoever's the most appropriate person. So thank you so much for joining us tonight, and stay safe and keep wearing your PPE. Thanks. Good night.